any of us to wear each other out in the process. Kim Holland is from Blue Cross Blue Shield Association, Vice President for State Affairs. Thank you for being here, Kim, and I turn over the microphone to you.
Thank you, Governor Christie, members of the Commission, and honored guests. I lead our system-wide efforts to respond to our country's opioid crisis. It is indeed one of the most pressing issues, public health issues facing our nation today, and our own data bears that out. Our recent Health of America report on opioid prescribing, which is being made available to the Commission, reveals that our Blue members diagnosed with an opioid use disorder spiked 493% between 2010 and 2016. On behalf of the association, thank you for the opportunity to join in this discussion. Blue Cross and Blue Shield companies are strongly committed to doing our part to combat the epidemic of opioid use disorder. We very much appreciate the actions you are taking to bring all stakeholders to the table, as it will take all of us working together to bring about the needed systemic change. You've heard from Mr. Swedish of Anthem, and we'll hear from Dr. Anu Patel of Blue Cross Blue Shield of North Carolina, 2 of the 36 plans within our system who are leading and engaging in collaborative initiatives to address this crisis in their local communities. Just as states' needs will vary, plan initiatives will vary in response. However, since early 2016, Blue plans have convened their mental and behavioral health, medical, and pharmaceutical experts with a shared goal of adopting policies and practices that ensure appropriate opioid prescribing, promote evidence-based treatment for substance use disorder, and reduce the occurrence of fraud and diversion of prescription opioids. As evidence of this unified commitment, allow me to offer a few examples that speak to some of the Commission's interim report recommendations. We support prescriber education initiatives. Blue plans have endorsed the CDC Guideline for prescribing opioids for chronic pain and are working collaboratively with the prescriber community to implement these or similar guidelines. For instance, Blue Cross Blue Shield of Massachusetts has instituted a program which implements best practices for prescribing opioids, including, among other practices, a treatment plan between the patient and prescriber outlining responsibilities and behaviors on both sides. A CDC study has praised the program, finding that it lowered the average monthly rate of opioid prescribing by 15%. And Dr. Patel will tell you about their successful prescriber outreach program in North Carolina. We support access to medication-assisted treatment. Blue plans cover medically necessary MAT and the associated counseling or behavioral therapy. Plans recognize substance use disorder as a chronic disease that should be treated as such. Plans work with physicians to ensure patients get the right care in the right setting at the right time based on each patient's individual needs and circumstances. And we're funding research in hopes of uncovering new insights that will lead to better treatment and prevention efforts for substance use disorder. We support wide availability of naloxone. Blue companies cover naloxone for members, and medical claims for naloxone have increased significantly over time. Additionally, many plans provide community funding for naloxone, ensuring access to all who need it. As one example, over the last 2 years, Capital Blue Cross in Pennsylvania has committed a total of $200,000 to fund the purchase of naloxone for municipal police departments. And we support enhanced operability of prescription drug monitoring programs. We encourage additional support to states that would improve the effectiveness and ease of use of PDMP systems. Currently, 37 states mandate some type of prescriber use under some circumstance. However, not all states allow physicians access to PDMP data before prescribing, and only one state permits health plan access to PDMP data. I would echo Ms. Greenberg and suggest that during the inevitable evolution of improved data sharing, health plans can serve as another resource. Analyzing PDMP patient data in conjunction with the plan's own provides a full picture of prescription drug utilization. Although Blue plans carefully monitor opioid use and potential misuse, there is a limit to what our data can tell us. For instance, if someone pays cash for a prescription drug, a claim is not generated. Access to PDMP data will fill in these blanks and promote more effective interactions with physicians to ensure a patient's safety as well as appropriate treatment. We support legislation to better align patient privacy laws specific to addiction with the Health Insurance Portability and Accountability Act. The association joined over 35 healthcare stakeholders stakeholder organizations in a letter urging Congress to support Jesse's Law and amend 42 CFR Part 2 to align with HIPAA privacy regulation, access, and use requirements. And we support mental health parity and addiction equity. We believe all Americans should have access to high-quality, affordable health care and coverage. Plans are vigilant in their compliance with the MHP AEA and offer comprehensive benefits that include access to evidence-based mental health and substance use disorder treatment. We have strongly opposed changes to any existing law that would erode comprehensive health coverage and not provide robust mental health and substance use disorder benefits. In closing, Blue Cross Blue Shield Association and member plans share your commitment to addressing America's opioid crisis and ensuring that those suffering with opioid use disorder get the care they need to place them on a path to recovery. Thank you so much.
Appreciate it very much. Now we'll turn to Dr. Nur Patel, who's the medical director from Governor Cooper's home state of Blue Cross Blue Shield of North Carolina. We are happy to have you here and appreciate your willingness to give us some information today. Dr. Patel.
Good afternoon, and thank you to the members of the Commission and everybody here for having us here from Blue Cross Blue Shield of North Carolina as part of this important discussion. As Governor Kersey mentioned, my name is Anura Patel. I'm a physician. I'm board certified in physical medicine and rehabilitation. Prior to joining Blue Cross of North Carolina, I was in private practice doing pain management and treating addiction with medication-assisted therapy. I feel uniquely positioned and fortunate to be here because I've seen the devastation from the opioid crisis from both sides, both as the provider prescribing the medications and treating the addiction, as well as now from the payer side. I'm currently on the Blue Cross Blue Shield Association level work group, which is chaired by Kim Holland. I'm also chairing an internal work group within our North Carolina plan. I'm also still clinically active. I continue to see patients in addition to my primary role at Blue Cross. Quickly, in general, about our North Carolina plan, we serve close to more than 4 million customers throughout our state. We're in every zip code of all 100 counties. We are our state's largest health insurer. We feel very passionate about the opioid issues because our state has 4 of the cities that are in the top cities in the nation affected by opioid issues. At Blue Cross Blue Shield North Carolina, we've heard this word go around the room about holistic approaches. We do support a holistic, well-rounded approach. We support and endorse the CDC guidelines, both on an association level and a plan level. We also support recent legislation passed this summer called the STOP Act, which Governor Cooper signed into law. Some of the provisions limit initial prescriptions for opioids and requiring providers to check the controlled substance registry. In terms of our local plan efforts, we have analyzed and we continue to refresh our data and analytics, which were developed to understand claims data, opioid prescribing patterns, outlier providers, costs. We have expanded our telemedicine program to include additional codes specifically for mental health. We work with our providers in a collaborative manner. We do view our providers as an extension of our plan. They are the providers' patients, but they're our members. We have provided webinars on CDC guidelines, on STOP Act legislation, on the North Carolina Medical Board, continuing medical education requirements for prescribers of opioids. We have sent numerous letters to providers, educational. We have targeted outlier providers in a very neutral fashion. We have posted blog posts on appropriate prescribing, CDC guidelines. And all of these have actually been well received by providers. As you can imagine, they're out in practice, busy all day seeing patients. So we've tried to create an information one-stop shop for all of them. In terms of member education, our care management nurses have been trained to target members who have opioid dependency or identify substance abuse. They make direct, proactive outreach to these members in a way that's engaging rather than intrusive. We've encouraged them to have conversations, not just about, I've noticed you got a prescription for, do you know how to take it, but do you know what to do with your medications when they're no longer needed? Do you know what signs or symptoms are of addiction? Do you know how to store these medications properly in your home? And encouraging them to even have the conversation with the provider as, do I even need an opioid for this? In terms of our pharmacy initiatives, we have an actionable point of sale edit message that alerts the dispensing pharmacist if a member is filling both an opioid and concurrently medication-assisted treatment medications such as Suboxone. There are currently quantity limits on all long-acting opioids. We have Narcan nasal spray as well as the self-injectable vial on a preferred generic tier. Prime Therapeutics, which is our pharmacy benefits manager, continues to send quarterly reports to members, providers, as well as providers providing information on suspicious high-risk prescription histories. We have partnered with Walgreens Pharmacy, both at an association national level as well as within our state, to have drug take-back kiosks throughout the state. We currently have 20, which will be across the state of North Carolina, and we're providing funds for an additional 22. So our goal is to get these medications off the street and out of bathroom medicine cabinets at our members' homes. Based on our activities thus far, we believe that we have to take a comprehensive approach, starting with preventing opioid misuse and addiction before it begins, improving addiction treatment, adopting stronger integration of behavioral health and pain management, building stronger community partnerships. We believe the public and private sector should work collaboratively to balance standardization of approach while also allowing for local flexibility in developing solutions. We also believe, along with a lot of my colleagues that mentioned this, that health plans need the continued ability to utilize pharmacy management tools and services to monitor and prevent overprescribing and diversion with broader access to PDMP. And finally, just to quickly highlight some of the ways we've worked collaboratively, we've worked on an association level on the substance abuse and mental health work group. We recently went to DC and testified at DHHS to the Senate Finance Committee. We're involved in a collaboration called We Care. We have enlisted our national accounts, labor industry experts. We're using them for dialogue and advisory for primary and secondary prevention. We've worked with the North Carolina Department of Health and Human Services. We served on the Prescription Drug Abuse Advisory Committee. We are on the Payers Council, where key payer stakeholders within the state of North Carolina are coming together to improve health outcomes. We've had several meetings with the Department Secretary of Department of Health and Human Services. We are also meeting with the in-state drug treatment facilities and Department of Health and Human Services to improve treatment within our own state rather than having members go out of state, as well as targeting key entry sites for referrals such as emergency room and primary care physicians. We have worked with the North Carolina Medical Board. They're having statewide continuing medical education panels. We will be serving on those panels. We provided input on the STOP Act legislation I mentioned earlier. We are collaborating with the medical board on how to manage these outlier prescribers. We are also meeting and working with the North Carolina Attorney General's office. We have a meeting again in December to work collaboratively and share our internal work group efforts. Finally, nationally, I participated on the National Appalachia Initiative through the Bipartisan Policy Center under Senator Tillis, where we gathered educators, business leaders, and advocates to come up with innovative solutions for many issues, including the opioid crisis. And locally, we are working on multiple state panels as well as sponsorships to raise awareness, to educate on opioid addiction and opioid use disorder, taking away the stigma, educating our providers, educating our members, and joining forces together. So with that, I'll conclude, and I would like to thank you for your time. And I would also like to say that we would like to continue to partner and collaborate with others, both on a state level as well as on a federal level, in helping solve this problem. So thank you.
Thank you, Dr. Patel. Appreciate your presence here today and your thoughtful remarks very much. Dr. Douglas Nemechek is the Chief Medical Officer for Cigna. We appreciate you being here, sir, and look forward to your remarks.
Thank you, Governor Christie. Good afternoon, and thank you to all the members of the Commission for the opportunity to be here today and talk about the opioid crisis that we've heard killing so many Americans, but also is killing careers, killing families, and killing our communities. At Cigna, as a global health services company that serves 95 million relationships around the world, we've seen the impact that opiates has every day. And we recognized really, as we've heard from some of my peers today, the impact is really threefold that we want to address. First, prevention and education to keep people from getting addicted in the first place. We want to improve care and treatment around pain and addiction of patients who are already sick. And we want to make sure that we reduce and eliminate the stigma around substance use disorders so that we're free to talk about this in our communities the same way we talk about other chronic health issues and chronic disease. Cigna came out 18 months ago and was proud to make a commitment to reduce commercial opioid use by 25%. Within the first year, we were successful at getting halfway there, and we're getting very close to that full 25% reduction already. But that's only the first of our goals. Without repeating some of the things that we're doing that are similar to what others, I want to highlight just a couple of things that we're doing that I think are a little bit unique or different that haven't been mentioned. First, in our partnership with physicians around the country, we've worked to encourage the use and following CDC guidelines, but we've also worked to have physicians sign a pledge with us to pledge to reduce opioid use and join us to start talking about opioid use disorders as a chronic disease. We've had over 270 physician groups representing 65,000 plus physicians sign that pledge to work with us. And then working with them, we've created a playbook of what they're doing in their communities that are best practices around how they work with their hospitals, their emergency rooms, and their physician partners in the community, so that we can share that information with other physicians across the country and hopefully allow those best practices to be implemented elsewhere as well. We're working very hard with building our network, too, around making sure access to substance use care is available, growing medication-assisted treatment network by 35% this year, and also making sure that through eliminating prior authorizations for medication-assisted treatment and services, as well as increasing and placing prior authorization on long-acting and short-acting opioid prescriptions, that we're encouraging patients to seek care where it is most appropriate. We're also focused on working directly with our customers who do have issues with opioid use disorder and chronic pain. We've expanded our case management programs such that not only are we sending information to physicians to alert them to their prescribing patterns of patients who look to have high-risk prescriptions, but we're outreaching to the patients directly so that we can engage them and educate them on appropriate pain treatments, alternative pain treatments, and alternatives to the opioids, and hopefully prevent them from ultimately having potential overdoses in the future. Lastly, as we've looked at this, understanding that we can't be the solution ourselves, we focused with partners in the community. We have partnered with Shatterproof across the country and even had 100 of our Cigna employees participate in their fundraiser in Hartford, Connecticut earlier this year. We've also taken steps this year to partner with the Iran and Afghanistan Veterans of America group to try to address some of the unique aspects that in the veteran community across the country, which we heard about earlier today. And later this year, we're opening up a dedicated hotline that will be open to all veterans, regardless of whether they're Cigna insured or not, to help provide support and services to those veterans. So I will wrap up with that. Certainly, we look at this as the first step in reducing opioid supply across the country. It's a necessary step, but it's not sufficient to truly fix the epidemic. We need to provide holistic and integrated care. And as a psychiatrist, I need to add that mental health care is an important piece of this. We've seen the studies that show 50% of opioid prescriptions are written for patients who have a comorbid mental health disorder as well. So we don't want to forget, as we talk about fully integrated and holistic care, the importance that mental health plays. So as we all work together to find these solutions, again, thank you for the time today and look forward to continuing to work with you.
Doctor, thank you. Thank you for your mention on the mental health aspect as well. Dr. Michael Sherman is from Governor Baker's home state, Harvard Pilgrim Healthcare. We welcome you here, Senior VP and Chief Medical Officer, and thank you for your time.
Thank you very much, Governor Christie and Commissioners. I represent Harvard Pilgrim, which serves over 1 million members in Massachusetts, New Hampshire, Maine, and Connecticut. We have a strong culture of supporting the community and working collaboratively with all stakeholders. We've all seen the impact of opioids on our members, on our communities, and we really want to be part of the solution. Let me also add, in the way of abusing anyone of stereotypes, I'm a physician. I trained with individuals. I worked with individuals, some of whom are dead from opioid overdoses, some of whom had their careers destroyed. These are people who understood intellectually the dangers. I assure you they were the people who in college were studying on Friday nights, not out partying. So if it can happen to people like that, it can happen to any of us, and we really need to take this seriously. We're actually fortunate that we have in our largest state, Massachusetts, a multi-stakeholder group, the Governor's Opioid Working Group. Through this task force, we're working with all the stakeholders to agree on solutions that can be put in place with clear and coordinated messaging. And again, that's really important. Health plans sometimes are not seen as being the best arbiter of solutions, and by having everyone approach this together with a common goal, we can put these things in place with less pushback. We also operate, though, in 3 other states, and having each state come up with their own practice can be confusing and create deterrence. So we strongly urge the Commission to look at best practices across states and come up with national guidelines that we can all adopt. This is a scourge that doesn't know any state borders. An example of something that we've implemented is actually emerged from the Mass Work Group, which is a first in the nation law, which said that individuals, adults getting new prescriptions for opioids were limited to 7 days for the first fill, and for minors, for all prescriptions. And for anyone, they had the ability to ask the pharmacist for something less than a full fill, and we think we'd like to see that proceed nationally. And I want to stress, if we had done that just as a health plan, I think we would have gotten pushback. Some examples of changes that originated within our health plan. We do cover naloxone without any prior authorization, but we don't just cover it. We've eliminated any cost share because we don't think that cost should be a deterrent to having these medications handy. We also, like many, cover all sorts and all types of medication-assisted treatment, again, without prior authorization. We do cover methadone maintenance, which in many areas is covered through public programs. We thought it important to add it. And when we learned that in some cases individuals have daily copays because of the daily treatment, we eliminated the cost share on that as well. We also look at the cutting edge treatments that are out there. There's a company actually based in Princeton, New Jersey that has an implanted buprenorphine for substance abuse for 6 months. By implanting, it eliminates diversion. It eliminates people not being adherent. As it came out, we made it available as a benefit to our members. Again, no prior authorization, no restrictions. If people need it, they need to get it. And we all need to be looking at these newer therapies and working rapidly to make sure members have access. We've also heard today about the importance of non-narcotic options for the treatment of pain, such as acupuncture to reduce the use of opioids. We cover acupuncture, but we go a step further, and we're actually working with some large employers to create on-site clinics so that their employees have easy access to acupuncture and other types of care. We're also working to broaden access to newer modalities, yoga, therapeutic yoga, mindfulness, et cetera. There actually are published studies that indicate the benefit of those for certain individuals, and there actually are specialists who, in those areas, who work primarily with pain patients, so it's important to make those available. We believe that abuse deterrent formulations are part of the comprehensive solution, but not a panacea. We're reviewing how best to incorporate these into our management approach. And for example, based in Massachusetts Chapter 258, we're ensuring that these formulations of opioids are covered in a manner that does not disadvantage them or make them more expensive than the abuse deterrent formulations. We're also considering innovative contracts with pharma companies that better align incentives with respect to the impact of their products, but are awaiting guidance from groups such as this and the Massachusetts Task Force before moving forward. I would note that there are a limited number of manufacturers making abuse deterrent formulations, so we urge the Commission to provide guidance that will ensure that the products are priced in a manner that makes them available to all who need them. One other thing we do, which is somewhat unique, we have a quality grant fund which goes back many years. Over the past few years, we've tried to focus on medical groups that can use these funds to help address the opioid crisis. An example would be a grant we gave to Maine Quality Counts, which works with many medical groups, and they have a law there that requires physicians to taper those patients who are on high-dose opioids. We gave them a grant to help with education, access to experts virtually, and other resources, training, et cetera, so that they can actually do that. I'm proud to say that thanks to these efforts and those in the community, the number of scripts for opioids per member are down 21% since 2014 to today. Again, that's not enough, and this feels like a balloon where you attack one part, it comes out somewhere else, so it doesn't mean we're even close to solving this, but it does show we can make a difference. Some of the challenges, and these are not new, so I'll be brief. As you've heard, health plans do not have access to prescription drug monitoring programs. I can look them up as a physician, but I can't share them with our pharmacist. Again, physicians are required in many states to query these before writing or filling a prescription. Using this information to help us get a comprehensive picture and determine early on where people are at risk and engage. Similarly, you've heard about 42 CFR Part 2. Again, I would ask the Commission to work to repeal that. Again, that's something that was put in place with best intentions to protect people's privacy. But the reality is that if we have data that suggests that there's a problem, we cannot reach out to a member's primary care physician and make them aware. That clearly is in no one's interest. One other comment I would make is that lack of consensus as to best practices can lead to friction among providers, patients, policymakers, and health plans. We believe that clear guidance from this commission can really help get us around all of those barriers. And finally, thank you for being here, and I appreciate your listening.
Dr. Sherman, thank you. Some really interesting things that have come out of your work in Massachusetts and New England. Appreciate you being here. Dr. Edward Ellison is the Executive Medical Director at the Southern California Pronante Medical Group. Thank you for coming. Look forward to your remarks.
Thank you, Governor Christie, and distinguished members of the Commission for the opportunity to provide Kaiser perspective in helping to combat the opioid crisis. This is a difficult and deadly issue that unfortunately touches us all. I am Dr. Ed Ellison. I'm a family medicine physician who also has the honor of serving as co-CEO of the Permanente Federation. In that role, representing the 21,000 Permanente physicians, provide care for 11.8 million members of Kaiser Permanente in 8 states and the District of Columbia. Kaiser Permanente is a coordinated, integrated healthcare system consisting of a health plan, hospitals, and physicians, all working together in partnership for the benefit of our patients. It's this structure that allows us to provide a comprehensive, strategic, and coordinated approach to addressing complex problems like the opioid crisis. That approach has improved patient lives and reduced the destructive potential of this epidemic in our community. Between 2014 and 17, we decreased high-dose opioid prescriptions by 39%. We decreased brand-name OxyContin prescriptions with their higher risk of diversion into our communities and schools by 75%. We've decreased adverse events in our patients and improved their ability to navigate their lives, with many reporting actually feeling better once they're off the opioids. A summary of our work is available in the peer-reviewed article that we're providing to you. So how did we achieve these results? Our data systems and clinical integration led us to recognize the severity of this problem 7 years ago, and that resulted in the development of what we call our safe and effective opioid prescribing program. Our overriding reason for this initiative was to assure our patients' safety. The cardinal rule in medicine is first, do no harm. We are committed to addressing our patients' pain needs, but at the same time, it's imperative that we do not create an additional and potentially problem for them. Our program consists of 4 elements: patient education, physician education and support, patient safety, and community protection. First and foremost, our patients need to understand the dangers of opioids and with what other treatment modalities are available to them to assist them in managing their pain. They learn that while opioids may be extremely helpful in managing pain, these medications carry significant risk. Education that's available online and in hard copy around alternatives, including non-opioid pain treatment medications, self-care, cognitive-based therapies, acupuncture, Tai Chi, and mindfulness training, and involving the patient in the decision-making process are all critical. We also believe that arming physicians with education and support allows them to confidently provide our patients with the expertise and treatment program that they require. This includes MAT and naloxone. In essence, we want to make it easy for the doctors to do the right thing. We've developed evidence-based clinical algorithms and decision support tools that are embedded in the electronic medical record, making physicians aware in real time of appropriate prescribing and treatment practices, as well as evidence-based alternatives to opioids for pain management. If an opioid is medically appropriate, ensuring the patient receives a treatment plan that consists of the right dose for the right duration tailored for the particular condition is essential. It's also about teamwork. Addiction specialists, mental health specialists, pharmacists, physical medicine and rehab specialists, and other experts are just a phone call or an e-consult away. Monthly prescriber-level opioid safety metrics and prescribing patterns are readily available to identify opportunities for intervention and improvement. And opioid utilization metrics are also available on patients to identify, track, and intervene as appropriate for patients at risk for overuse, abuse, or drug-seeking behavior. A more holistic approach has allowed us to taper patients' medication regimens even when starting at high doses. We know that cutting off a patient's opioid prescription is not an option, as it may drive them to seek the drugs in other settings, including the street. Opioid addiction treatment requires commitment and forming long-term relationships with patients. By establishing a bond of trust and better understanding the patient's underlying medical, psychological, and social needs, we've been able to incorporate adjunctive treatment options and a trusted source of help. Kaiser Permanente's mission extends to our communities as well as our patients. We've reduced the prescribing of higher risk of diversion brand name opioids, and we share our successful practices outside our organization and across the community. We also continue to learn and improve. We believe a successful approach requires a strong physician-patient relationship, data-driven evidence-based decision-making, multidisciplinary team-based care, the use of modern technology, and old-fashioned behavior change in an integrated system. We're ready and willing to work with all stakeholders to address this critical national issue. We thank you for the opportunity to share our story and to be of service to those who need our help. Thank you very much.
Thank you, Dr. Ellison. Appreciate that. Fascinated to hear some of the results that you've gotten already. It's very interesting. Dr. Migliori, Executive Vice President, Chief Medical Officer of United Health Group. We appreciate you being here. Large player in this field, and we appreciate your presence.
Thank you, Governor Christie, and to the members of the Commission for the opportunity not only to share our thinking, but for the broader collaboration that your work is going to promise. Our enterprise is very concerned about the impact that the opioid crisis has had on Americans and not just our own clients. And our enterprise is fully engaged in delivering a variety of solutions to meet the objective of, first, preventing the next individual from developing opioid use disorder, and second, to rescue those already afflicted by getting them access to treatments that work. Our prevention solutions are multidimensional and include, first, analytics, using our big data assets to first characterize prescribing patterns. You know, despite the fact that the CDC guidelines have been out for 20 months, only 55% of prescriptions are written in conformity to those guidelines. All right. Yeah. Second, these machine learning has helped us to be able to create our first generation patient predictive modeling tools. We're able to identify the 2% of the population that are going to get where 60% of them will go on to develop opioid use disorder if we don't intervene. And third, and very importantly, getting to General Rosenstein's comments earlier, fraud detection. Rampant in an environment where people are driven by the disease to compulsive behaviors and people take advantage of it. We undertook 71 formal investigations in our fraud unit last year and made 384 referrals to federal, state, and community level law enforcement and regulatory agencies based on the behaviors we witnessed. The second thing we do for prevention is at the level of the pharmacy, scrutinizing each and every opioid prescription to look for conformity with CDC standards. Just in 4 weeks, in our initial 4 weeks when we put in the program to show the opportunity, we saw an 82% reduction in first fill prescriptions to the recommended CDC dosing. 82%. That's how much fat there's in the system. This last thing we talk about in terms of prevention is finding alternatives. We've been expanding our already 80,000 provider-strong base of physical medicine people, including physical therapists, PM&R physicians, as well as chiropractors. Because what we found out is when people with such things as back pain, a very common cause to get your first opioid, when people went to one of these docs or practitioners to get their therapy, only 5% of them ever ended up with an opioid for that episode of back pain. Whereas if they went to other specialties, it was over 13.4%. That's 62% fewer opioids for acting in that way, and for that reason, we continue to promote patients receiving alternatives because we think it works. Final thing is the issue about treatment. And let me start off by saying parity isn't just the law. It's an imperative in order to be able to treat this disease. This disease is a chronic disease, much like diabetes and heart failure and the like. The treatment has to be ongoing. It has to be delivered in a way that aligns with evidence-based medicine. In the case we've used is to build out the capacity and access to medication-assisted therapy, competent people for when it's indicated, and other forms of therapy when other alternatives are called for. We now have some 4,836 locations across the nation offering this, and a 24/7 phone line that will get people in typically within 24 hours for this kind of management. The other thing is to make sure that the drugs that are important for the use, all types of drugs, whether they're partial agonist and antagonist combinations or antagonists themselves, are readily available at the hands so that when that first opportunity to engage one of these patients occurs, it happens. The final thing I'd say is we've seen some meaningful and measurable progress, but there's a lot of work to be done and a lot of new investigation, including opportunities to really look at the PMDP databases as more than just a place to look at cases, but as a place where we could start looking as a patient registry to find best practices. And with that, I want to give our appreciation for being included in this conversation.
Thank you, Dr. Migler. I appreciate it. Our final presenter before questions from the members of the commission will be Diane Holder. She is the president and CEO of UPMC Health Plan. Thank you for your patience, and we look forward to hearing from you.
Well, thank you. I really appreciate being able to offer testimony today and appreciate the great work that you're trying to do. Pennsylvania has been particularly hard hit, and we're in one of those epicenters when you come up from West Virginia into Western Pennsylvania. I am part of a large academic medical center. We have 40 hospitals and almost 5,000 physicians, cover about 3,000 lives through our insurance infrastructure. And like Kaiser, I think we have the opportunity, because we can work hand in glove between our physicians and our hospitals and our insurance company, we sometimes have a view that's a little more holistic. And be able to share that data and be able to look at best practices. But I think the other thing that's really very important in terms of our environment is that we train about half the physicians in Pennsylvania. We train most of the nurses. We train the pharmacists and the physical therapists. And the incredible importance related to how do we get to the next generation of practitioners to really understand that, yes, pain is incredibly important, and we all have an obligation to use our best science to control pain in whatever way we can, but we have to look at the downside. Before I was running insurance companies, I ran our large psychiatric systems, and so my background is in behavioral health and addiction treatments. And so to me, when I look at what's happened historically in our country, for folks. I remember when the Los Angeles County Jail was the largest mental health center in the country. Perhaps it still is. And I think one of the key messages I would have for the group today is that is the partnership between public health and public safety that has to come together, but in a unique and novel way. So a year ago this month, because we, like you, have been working on the opioid problem for many, many years, we held, our insurance company hosted for our network a large gathering, a large conclave. And we had the U.S. Attorney, who had been very active working with us, the School of Public Health, the medical school, the nursing school. We had federal and state representatives of hospitals, doctors, our insurance company, families who were trying to help their loved ones, and people in recovery. And it was a day of dialogue where we basically just needed to hear from each other in terms of what was missing. And I would say if there was one thing that I think it would be really important for this commission to do, it would be to try to figure out how do you fund communities to come together. And I know there are some grants being issued, but how do you fund communities? Because healthcare is local. Their resources are different from place to place. The epicenters are different. The prevalence rates are different. We are seeing fentanyl as the leading cause right now of what we're trying to get out ahead of. It's devastating. There were 8 deaths in 70 minutes a couple of years ago in one of our counties, just 20 miles from our headquarters. So we are doing what we can, and I would say pretty much the strategies you've heard today, I think are best practices. I think the industry is trying to, look at formularies and look at how you can get in front with, authorizations for certain things. But when you look at what we're dealing with, we are dealing with subpopulations. The reason people become addicted is different. There are different groups of people, and the solutions have to be different for the different subgroups. And that's why I'm saying if you can help local communities with funding, if you can get rid of some of the privacy problems that we have that people have mentioned, and if you can help us come together differently, I think we could do something different and really get on top of this in meaningful ways. So I don't want to take any more time. I would just say ditto to most of the things I've heard here, and welcome your questions.
Diane, thank you very much. And I want to go first to Congressman Kennedy for any questions or remarks he has.
Thank you, Governor. First, let me just repeat that the historic treatment of addiction and mental illness has been a separate and unequal process. All of you as insurers and payers have treated mental health and addiction as if it's something other than the rest of medicine. So we're in the midst of really a new era, much like when we passed the '64 Civil Rights Act. We had to now begin to implement. Not treated because their illness is an illness of the brain.
Whether it's 90% plus of the world's opium supply, 90-fucking%. That is a multi-billion-dollar business. And if you think these fucking industrialist cocksuckers that are running the world are going to leave that money behind, you're fucking crazy.
So we are doing what
Dude, they've got United States Army troops guarding Poppy Field. There's fucking so much heroin there. I mean, it's incredible. The fucking brother of the president of Afghanistan. His brother was selling heroin and getting paid by the CIA. I mean, god damn it. Heroin is absolutely addictive, okay? People who try heroin
come up from West Virginia into Western Pennsylvania. I am part of a large academic medical center. We have 40 hospitals and almost 5,000 physicians, cover about 3,000 lives through our insurance infrastructure. And like Kaiser, I think we have the opportunity, because we can work hand in glove between and our physicians and our hospitals and our insurance company, we sometimes have a view that's a little more holistic, and be able to share that data and be able to look at best practice. But I think the other thing that's really
longer have pre-authorization on MAT and fail first. It was because the Attorney General of the state of New York put them into a consent decree. And the fact of the matter is we shouldn't be relying on one Attorney General in one of the 50 states to be really trying to enforce federal policy with respect to parity. Many of those who are in this room were in charge.
Thank you very much. And I want to go first to Congressman Kennedy for any questions or remarks he has.
Thank you, Governor. First, let me just repeat that the historic treatment of addiction and mental illness has been a separate and unequal process. All of you as insurers and payers have treated mental health and addiction as if it's something other than the rest of medicine. And so we're in the midst of really a new era, much like when we passed the '64 Civil Rights Act. We had to now begin to implement it and ensure that people are not treated differently simply because their illness is an illness of the brain. I appreciate Secretary Acosta's strong endorsement that parity needs to be strongly enforced. And I want to thank Amy Turner, who's here from his office, who is in charge of that oversight. But as he said, they are ill-equipped to properly deal with that oversight given the current statutory authority. And I appreciate you, Governor, agreeing that we need to enhance that authority in order to be able to hold accountability where it needs to be held amongst many of those who are in this room who are in charge of trying to ensure that that accountability takes place. The fact of the matter is, as Frederick Douglass said, power concedes nothing without demand, never has and never will. And there's a reason why some of these companies in this room no longer have pre-authorization on MAT and fail first. It was because the Attorney General of the state of New York put them into a consent decree. And the fact of the matter is we shouldn't be relying on one Attorney General in one of the 50 states to be really trying to enforce federal policy with respect to parity. I believe, as many of these payers are part of, trying to get clarity on what those common law standards of what falls in, the parity law, what falls out. How do we better define the non-quantitative treatment limits? Because that, Governor, is where the rubber meets the road. We've dealt with the quantitative co-pays, deductibles, lifetime limits, and premiums, but what we really need to deal with now is those non-quantitative treatment limits. The application of medical management practices. Just to reiterate, the law says inpatient, in-network, outpatient, in-network, inpatient, out-of-network, outpatient, out-of-network, pharmacy and ER. They must be compatible for mental health and addiction just as they would for the rest of medicine and surgical care. We need strong analytics, comparability, analytical tools that are agreed to, and I appreciate the support of many in this room, in order to apply those evidentiary standards, as has been said already, in an equal way across all of you as payers, so that there is a bright runway as to what that comparability needs to look like, especially as the field of addiction medicine evolves and as our knowledge as to how to better treat this illness evolves. Let me say, I do not believe the costly inpatient treatment that many of you providers are paying for out of network is the evidence base in most cases. And you're stuck having to pay for it because of parity, frankly. And I'd like to see that per capita payment that you're spending on that inpatient spent on the community resources and supports that will allow them to maintain their recovery with medication-assisted treatment if they have an OUD, which is, by the way, ASAM standard criteria for evidence-based treatment. But we all need to work together. And I would ask Pam, since she kind of represents the association, to talk about the need for those kinds of common law standards that could be helpful for providing that common nomenclature amongst all plans as to what really qualifies as a parity violation per se.
Thank you, Congressman. Appreciate it. And as you know, we were leaders in supporting and getting the passage of the repeal legislation. Thank you. And now our members are working diligently to implement the law and frankly understand the law. There are a lot of gray areas, and we meet with Amy a lot to make sure that we understand and implement them well. But one of the other things that we're working on, because we share your concern that there is not consistency in understanding and implementation at mostly at a state level, frankly, and being asked for different pieces of information, different types of analyses from each state. We're working with the Center for Healthcare Quality Improvement, CHQI. It's a group of stakeholders that are working to try to develop a parity accreditation tool so that we can have that commonality that you're talking about in understanding what we believe is expected of the law and the regulations, and in how we then respond to the requirements.
Well, thank you very much, and I thank you, Governor, for giving me the chance to speak about this, and especially the chance to help represent this commission and follow on meetings with Secretary Acosta and with Amy Turner. So thank you.
Thank you. I want to turn next to Attorney General Bondi.
Thank you. And thank you for letting me go after Congressman Kennedy, because we share many of the same views. In fact, I have personal friends who are in a pro bono capacity right now suing over parity violations. We've got to work this out. This parity stuff, we've got to work this out. We've got to. But we're not going to stop until we do. We need your help on it. Desperately. So, Congressman Kennedy, thank you for everything you've been doing on that issue. I spoke plenty last time. I just want to
you, Pam. Governor Cooper. Governor Baker.
I'm okay.
All right.
I have
Professor,
lots of things I'd like to ask about. We'll be here until Tuesday.
Professor Mattress.
I'm just going to fire off a few questions, and anyone who wishes to weigh in, please feel welcome to. Screening for opioid use disorder, is it a requirement for reimbursement if you are going to project and develop measures to cut down on opioid prescribing? Because we are aware that a number of people transitioned to heroin and fentanyl because they were cut off at the source. And so why or why not is there a mandate to require screening for an opioid use disorder before a primary care physician cuts down on opioids? The second question I have is, there is a very good evidence that most primary care physicians are unaware of their patients having overdosed. There is no communication between emergency departments or first responders and primary care physicians that's mandated across the country. And I'm wondering if AHIP and AHA, the American Health Hospital Association, should get together in coordinating that kind of information flow between health insurers as well as hospitals and other first responders. The third thing that I would like to question is whether or not, based on the CDC guidelines, is there a consensus that they are adequate? Having arbitrary cutoffs of 3 days or 7 days has received some pushback from certain medical specialties. Others have said there isn't enough time, there aren't billing codes to explain alternatives, and I'm wondering how the insurance companies would address it. And finally, my final question, and I have at least 8 others, but for brevity, I'll keep it to this. If every major health insurance company and CMS have specific goals, metrics on cutting down on unnecessary prescription opioids, why not have the unified goals? Why are there such disparities between you with regard to what you hope to accomplish, and also how to protect patients who in fact have progressed to addiction? And included in that, in terms of patient protection, is the absolute need for screening for substance use disorders prior to prescribing these drugs, as well as mental health.
Let me respond to maybe 1 or 2 questions. Thank you for asking those. Under 42 CFR, which was discussed earlier, to your point, if a health plan becomes aware of a patient having a drug overdose and going to the ER, we're not able to inform the primary care physician. If the ER is part of their system, they may learn anyway, but if not, they probably won't. So again, we ask your help in eliminating that barrier because we really would like to inform them. One other point, I'll just briefly, you spoke about why do we have different targets. I would love this commission and some of the work groups, and some of this is happening organically, but the states have their own approaches, and everyone is well-intentioned, et cetera. This commission is well-positioned to come out with appropriate targets and measures that we should all work to promote.
So let me add one thing to the targets. From the Medicaid and Medicare perspective, if you look today, right now in Medicare, health insurance plans, health plans are handling about 1/3 of those individuals. They are also handling, in states, probably about 75% of all the Medicaid. So you're right, states may want their own specific targets, but I think for CMS, HHS to set some targets that we could all work together to create makes a lot of sense, because so much of it is government funded, all or in part.
Anyone else want to respond to?
Yeah, I just want to add a couple of things. At Cigna, we have 180, 200 accountable care organizations, primary care groups that we're working very closely with on these very issues. They are begging us for more information on their patients' mental health and substance use disorder histories, and because of 42 CFR, you heard, we're unable to share a lot of that information and data with them. Where we are working with them is, to your other questions, of educating them on how best to screen, how to set up integrated systems of care, either by embedding mental health and substance use professionals in their primary care groups, or bringing that in virtually or from the community to support that integrated and holistic care. So it really is, there's a lot of education and a lot of building of the system to allow that care to occur there in the primary care setting.
I think regarding this, I was just say regarding the CDC guidelines, before we even begin to talk about changing them, we have to make sure that physicians and dentists and providers that prescribe in all 50 states are fully aware of those guidelines and are actually acting consistent with them. I have to say, we recently visited one community in a state that has been devastated by the epidemic, and it was shocking to me the lack of understanding of those guidelines and how, in some cases, poorly enacted they are. It's incredibly important that we start there, and this education piece, beginning in medical school, beginning in dental school, all the way through residency and practice, is extraordinarily important.
And I'll just echo what my colleague said, which is that I think it's important for our providers to understand the CDC guidelines, but I'd also like to say, with my physician hat on, that there's not a one-size-fits-all. So there are going to be patients that will be outliers from the CDC guidelines, and those are entirely appropriate. The key is if the physician understands how to manage that patient, understands how the opioids work, and is monitoring the patient to make sure that they're taking them appropriately, that they're not being diverted, that they're not taking other medications concurrently that would cause side effects. So what I would say, again, along with what he says, is that I think the education piece is important, because when we sent out letters, we had providers not understanding CDC guidelines, not understanding sort of the basics because they were not taught it, number one, and number two, they're too busy in practice to keep up with everything. But there are going to be providers that will be managing patients that will fall out of these guidelines. And that's one of the things that we've talked with the North Carolina Medical Board as well, is that they are meant as guidelines. So just like with opioids, or just like if you're managing a patient's hypertension or diabetes, there might be occasions that you go above what the recommendations are, and it's entirely appropriate for that patient if it's being monitored appropriately by the physician.
Diane?
And what I was going to add is the question around how do we get screening and training. I think we have a tremendous problem in our rural areas where we have a lot of this kind of opioid problem. And one of the things, our state has just received a SAMHSA grant, and they've contracted with us as the primary contractor to basically train the rural communities and physicians in trying to figure out how do you screen. And if you're going to do medication-assisted treatment, which is what we're hoping we can facilitate, you have to help people to train them to do treatment plans. Very few of the current physician community got much, if any, training on addiction in medical school. I mean, it's just not something that was spent a lot of time on. And so we need really to help people learn that. And as we know, addiction and mental health are co-travelers. Depression is often a co-traveler, and we have to treat people and look holistically. So it's not just as simple as an addiction, which is never simple to begin with. It's a really more complicated issue.
If I could just add quickly on the CDC guidelines, I mean, we endorse them. I think to the earlier point, physicians today, studies show that they're spending, for every hour they're spending with a patient, they're spending at least an hour in documentation and in paperwork. So it's an overwhelming amount of work to do to take care of patients. And so we need to make it easy to do the right thing. We need to embed it in their day-to-day life and make it easy to do the right thing and provide access with telemedicine and other resources. It is correct that the guidelines are a great foundation, and there is an opportunity to have an opportunity with telemedicine and other ways to connect specialists and primary care physicians to know when to refer and when to ask for help to customize to that patient.
I just foresee the decline of supply with regard to prescription opioids in the future being a problem that is relatively containable, but the Justice Department's role will increase dramatically over the next few years because of the increase in use psychoactive substances. And I think the insurance companies that are represented here are going to have to take care of patients of a wide range of addictions to opioids, which are derived either iatrogenically or through illicit sources.
I want to turn back to.
One more question is MAT. Obviously, we've got such a dearth of physicians who are trained to provide the evidence base that's going to help us address the immediate crisis of people out there. I'd like to ask the folks here, how do we get the rest of the physician community, i.e. not your addiction folks, but the rest of your physician community to throw in with this crisis and actually train up to be, authorized providers, and maybe do it in partnership with some of your community health folks to help them so that they're not feeling as if they got to take these patients on all alone, but if they have the support, maybe they'll start meeting the need that's out there.
We're training a lot of our primary care doctors to actually deliver these treatments, and we're embedding mental health specialists in the primary care offices.
I'd say the same thing. In our system like ours, we train the physicians, we can monitor, we have metrics to measure, we can again embed it in our electronic medical record, the protocols, the guidelines in real time as they're taking with the patient in front of them. They know they have the triggers right there, the guidelines, and they have immediate access either by phone call or e-consult to the specialist they need. So it's a network that we can provide a lot of support to, education around, so the physician feels supported in doing the right thing.
If I may, I was just going to add, and I think that's an important thing in terms of the support. What we hear from physicians across the country that are part of our networks is we're dealing with very complex patients. And aside from just training in terms of the delivery of an MAT, it is really dealing with the patient themselves that are complicated, that oftentimes don't want to be treated or are resisting treatment. So I think it goes beyond just how to administer MAT and more broadly about the complexities, the psychosocial and medical issues related to these patients that are going to have to be addressed fundamentally.
I just said we have a program on how to have the difficult conversation with the patient. That's not an easy thing to do. And so just training in that goes a long way in making the physician more comfortable.
And you have to have, I think, what you're saying, the team-based care that surrounds it. So, for example, primary care, given the limited amount of time you have in primary care, cannot do this by themselves. And so, I think some of the things that we knew 20 years ago or 30 years ago and how you help people with serious mental illness or addiction, you need crisis treatment teams, you need in-home teams, you need people with addiction specialty to be able to actually be in the community and go to where people are, because it's what you said, people aren't necessarily running towards you to get the care they need, but you'll find them soon enough in your emergency room.
Governor Baker.
So I very much appreciate all the conversation. I was going to pass, but I'm just going to throw out a few thoughts, and if anybody wants to respond to them, feel free. One is next week we have a whole bunch of people from the pain business and a whole bunch of people from the addiction world meeting in my office. To the best of my knowledge, that's never happened. One question I would have for you folks, and this is more of a thought, you should just think real hard about getting the pain people and the addiction people in the same place. They don't talk to each other. They never have. They really should. They would learn a lot from one another, I think. My second thought is we all give out CPACs for antibiotics, 5-day, just take this for 5 days. I think part of the opioid epidemic came about as a result of docs just writing 30 and 60-day supplies for pretty much everything. I would love it if the insurance industry and the physician community would say, how about a 3-day CPAC equivalent for opioids, for dentists, and a lot of the baloney that, frankly, you probably shouldn't give anybody an opioid for at all, but they're still getting them. And even in a state like Massachusetts, where we have a 7-day limit on first prescriptions and a really terrific PMP that, had 5 million inquiries last year and a 25% drop in overall prescriptions, every single day somebody tells me about somebody getting a 30-day supply for something stupid. And I think part of this is if we really want docs and dentists and nurses and everybody else to write 2 or 3 pills or 3 days. We've got to give them a packaging solution for this that works. I don't know what it looks like, but it's just not going to happen if everybody's just doing what they've been doing forever. It might happen by 2025 or 2030, but it's not going to happen before that. And I think it would be great if somebody came up with a solution that looked more like the packaging solutions people did for antibiotic treatment. The third thing is, 60 Minutes did a thing last week that basically said you lost some of your authority to chase drug distributors and to make arrests and to deliver on your enforcement opportunities. In Massachusetts, fentanyl was present about 17% of the time in 2014 in opioid deaths. Now it's present in about 80% of the deaths in Massachusetts. If you took fentanyl out of the mix, you know, our heroin and opioid numbers have dropped like a rock over the past few years. But because fentanyl has sort of come in to replace it, it's totally changed the game. I agree with you. If you don't have the tools you need to tell us what tools you need so that we can make sure they get into the report and you get back whatever kind of authority you need. And that is hugely important with respect to this particular issue. And then my final thing is, in diabetes, many forms of cancer, high blood pressure, mental health, pediatric asthma, asthma generally, across almost every area I can think of that's sort of traditional medicine, people have some idea about how to keep score about whether or not we're succeeding and how we're doing. I would argue that